Welcome to Taking the Pulse, a healthcare and life sciences podcast. I'm Tina Emerson, here with healthcare attorney Matthew Roberts. Good to see you today.
Good to see you.
Today, we're also joined by two more members of the Maynard Nexsen healthcare team, attorneys Jennifer Hollingsworth and Ralph Barbier, who are in the studio to talk to us about significant regulatory changes in South Carolina, including the South Carolina DHEC restructuring bill and the State of Certificate of Need, or CON laws, in South Carolina. Jennifer and Ralph, thanks for joining us today.
Happy to be here.
On a prior episode, you talked about a strong effort to repeal CON that did not pass in the General Assembly last year. And this past legislative session, the General Assembly did pass CON legislation. So tell us about what happened.
Yeah, interestingly enough, we looked a little over a year ago. Ralph and I sat, well, not right here in another room, but came on and talked about the state of CON and a strong push to repeal the program, Certificate of Need program. It did not happen last year. And here we are 13 months later, and CON has been effectively repealed in South Carolina. It'll take a little time for everything to kind of take care of itself, and we'll talk through that. But a year ago it didn't happen at all, and now here we are, and the program has been kind of gutted, would be one way to say it. So there's a lot of changes in store.
So what do you think happened that created this desire to eliminate this regulatory framework that's been in existence for decades in South Carolina and did, from a health policy standpoint, did help regulate the growth of healthcare facilities? What happened? What was the big concern about CON?
Well, we know last year the repeal movement, which was a strong movement. I mean, it came out of the Senate. Legislation passed the Senate, and we, from 30,000 feet outside view, it was a strong push driven by physicians, surgeons who really wanted to develop facilities and services like ambulatory surgery centers, and felt limited in their ability to do that because CON, that regulatory scheme, it's expensive, it's burdensome, it can be litigated, so those are some of the frustrations. And so I think from that was born a directed and successful movement, at least in the Senate. It did not make it through the House last year. And I think we see a lot of that in what happened this year with some tweaks and nuances. But I still think it comes from a more provider perspective.
Right.
And yeah, it's kind of where we ended up.
And I think if you look at what happened in 2022, the sort of the battleground in the legislature really was about ambulatory surgery facilities. That's where I think most folks thought it would be ultimately resolved, would be on ambulatory surgery facilities, and maybe perhaps giving physicians, independent surgeons, the ability to move forward and develop their own surgery centers without having to go through a cumbersome regulatory process like CON. Well, when that didn't occur in 2022, you roll into 2023, and the Senate, again, picked up where they had left off, and they went with a full repeal for the most part, except for nursing homes. But then it went to the House, and again, I think folks thought, well, maybe it'll get caught up again in the House, and maybe there'll be some compromise, and ambulatory surgery facilities will again be the focus. Well, it really got some legs in the House, and I think those who had been pushing for this program to go away for 10, 15 years really saw an opportunity. And then, as Jennifer and I kind of laugh about it, I mean, you look at it, not one legislator in the end, either in the Senate or in the House, not one, supported the program. It was effectively, it was unanimous in the Senate and in the House, and I'm not sure how much legislation gets passed these days in any state capital where it has 100% support in both chambers, both parties, and that's what happened here.
So this is a trend, scaling back or repealing CON, that's been happening in other states, right? In the Southeast in particular.
It has, and I think most notably Florida really, I think, set the mark. At least in South Carolina, a lot of people look to Florida, which had a major CON reform repeal type bill go through. I think it was 2018, 19. Yeah. Mm-hmm. And you see what happened in Florida, which now we know that in Florida you had some 20 CON applications pending in, I think, 2018 or 19.
For new hospitals?
For new hospitals. Right. They repealed the bill as to hospitals, And then you now have some 60 to 70 new hospitals that were built since then.
Since that repeal.
In Florida. So I think a lot of people expect that's what's going to happen in South Carolina. We know from our experience, just since the governor signed the bill into law, Governor McMaster, the calls that we're getting we're getting many calls, folks really looking now to South Carolina. And it's going to be interesting to see. I think there will be a proliferation of healthcare services. Whether that's good or bad, I think what remains to be seen. But it's going to be, South Carolina is going to be a very active state, whether it be for new hospitals, and we can talk in a second. There is still CON regulating hospitals, at least for the next 3.5 years until January 2027. But now ambulatory surgery facilities, equipment purchases,
all that's
gone. It's green lighted immediately, right. and South Carolina's wide open.
So let's talk about the hospitals and how there's a sunset provision in this legislation that was passed and signed by the governor that does keep CON around for some 3 years. Explain that to us.
Yeah, and so that's sort of the effective repeal, just meaning, and I think the department is calling it a partial repeal, maybe is what we've seen, but well, first you have to carve out nursing homes. Nursing homes will continue to be regulated in that they'll continue to need a certificate of need before they can be developed. But other than nursing homes, all that is left in terms of facilities regulated by a certificate of need are going to be new hospitals, so the development of new hospitals, or a change in bed complement for existing hospitals. So if you're trying to add general acute care beds, if you're trying to change specialty beds to acute care beds, those will still need a certificate of need for a period of time. And the sunset provision says that element of the law, which is related to the development of new hospitals or bed complement changes, that also goes away January 1 of 2027.
So what do you think the policy reason behind having a sunset as opposed to an immediate repeal? What were the legislatures? What were they thinking about doing that?
Well, of course, the South Carolina hospital industry has been very concerned about the repeal of CON. The South Carolina hospitals have a lot of money invested in providing services to their communities, and the concern being that we have all this invested. We have a lot of requirements with respect to treating patients and those folks who come to the hospital emergency rooms, and so an immediate repeal of CON with respect to hospitals, I think it was thought that might be too quick, the impact too potentially severe on the existing hospitals in the state. So the thought was a compromise would be to have a sunset period that allowed the transition. And remember, I think to build a hospital anyway, to develop the plans and construct a hospital can be 3 to 4 years, 5 years. So there was a natural transition going to occur anyway, but I think this really gave the hospitals in South Carolina some breathing room to kind of think, consider where they are and what the impact's going to be. One note I will say on that point is some of the calls we've been getting, and I think one of the issues is that the sunset period just says that a new hospital cannot be constructed or otherwise. And I think the phrase is
construct or otherwise undertake
the development. And so I think some of the question is, well, what can we do during this period to maybe design the plans and get prepared for January 2027? And so I think you're going to see a lot of folks testing that as to what, in fact, the legislature meant with that phrase. So I think that's something that's going to be looked at and people are going to push on some.
Well, let's talk a little bit about the potential impact of the proliferation of healthcare services. Sort of in theory, for people who are healthcare consumers who don't work in the industry, it might be a good thing that there's going to be more hospitals, more ASCs, ambulatory surgery centers, more imaging centers, but that's not necessarily consistent with health planning policy, and that's why we have the CON laws to begin with. So if this CON framework's gone, what's going to replace the regulation of healthcare facilities going forward?
Well, and of course that's one of the issues. So if you look at it from a certificate of need in South Carolina, at least, I think the benefits certainly was that for services like cardiovascular services, take that as an example, CON is really what regulated that service. There's no real specific licensure requirements or regulatory framework around cardiovascular services.
Like open heart surgery, cardiac catheterizations.
You have therapeutic and diagnostic caths. That was all sort of under the CON framework, and it really was a pretty stringent framework where you would have to go through your certificate of need application and be able to demonstrate to the DHEC that there was not only just a need, but also that you had the ability to provide the service. And of course, open heart and therapeutic caths would have to be in a hospital, and diagnostic caths, even though it could be done outside a hospital, very strict regulatory framework. Well, all of a sudden you repeal CON, and from one day to the next, literally, on the governor's signature, it took effect. Now it's wide open in terms of cardiovascular services, in terms of open heart, therapeutic caths. Now I don't believe there's any state law requiring a therapeutic catheterization to be done in the hospital. So those are things that, from a quality of care standpoint, that what I would expect, and Jennifer and I have discussed this, what I think we would expect is that folks are going to realize there needs to be some regulatory parameters around a lot of these tertiary services, and that means maybe a more robust health licensing regulations around these services. And then the question is going to get into, well, can DHEC do that by regulation, or soon, as we talk about the restructuring bill, is going to be the Department of Public Health. Can they implement regulations to deal with that, or is some of that going to have to be done statutorily?
Well, before we make the shift to the DHEC restructure, one of the final questions about CON is, if the physicians were in favor of removing CON, I guess if they own ASCs, they'll just be competing with one another for patients and market share. And so what do ASCs need really to be competitive now that we have this no CONs in the way? There's not a regulatory framework. There are ASC licensing requirements. But what do ASCs need to be effective? They've got to have physicians, but what else do they need?
Well, I mean, obviously staffing, I think what you're going to see, set aside the physician component, but when you look at one of the issues that's going to be interesting, we are already short-staffed, particularly in the world of nursing in South Carolina, like many states. And I think what a lot of people lost sight of with regard to the CON debate, folks looked at it like it's all about the money and it's and precluding competition and those types of things. But on the flip side of that, the folks that supported CON, I thought, made very compelling points, which is when you have limited staffing, particularly in the medical field and in nursing and in other medical professions, the one thing CON really did and accomplished by having this deliberative process is when you didn't have the proliferation of facilities, it allowed, I think, for a more balanced staffing around the state. Well, now if you have ASCs, ASFs opening up on not every street corner, but maybe every other street corner, I don't know what it's going to look like, hospitals, other things, it's going to be difficult.
It's going to interfere with the ability of hospitals, probably primarily. I mean, so
because it's an easier job to be a nurse
if
at ASC.
I'm going to go work at the outpatient center where at least I know,
your hours
I'm not there overnight or whatever it might be, and so you're going to have services at hospitals, I think, just significantly impaired. I mean, even today, with the regulatory process, and I do the litigation piece of it, and staffing is just a tremendous part of it. We've had a nursing shortage in South Carolina for decades, but with the impact of COVID and what COVID did on the workforce, and particularly the nurses, for example, tend to be more females. Females tended to end up home with COVID and maybe either choosing not to or having a difficult time getting back into the workforce. The nursing staff, specialty nurses, you have hospitals today that can't open units, aren't providing certain services because you don't have the bodies to do it. And that could be a really strong negative, effect of what's coming.
And Tina and Matthew, one of the things I wanted to point out on that point, because I think this is really important, the one part of this bill that passed, this CON bill, which was very interesting on this issue of staffing and proliferation of facilities, was that the legislature now has sort of tied the hands of hospitals with respect to sort of protecting their own ability to compete. And they did so by now prohibiting hospitals, just hospitals, from using economic criteria. And in the hospital, I think in the healthcare world, it's referred to as economic credentialing, sometimes referred to as conflict of interest credentialing. But the South Carolina legislature has now said to hospitals, you cannot use economic criteria in deciding who to admit onto your medical staff. And if you think about that, so if a group of surgeons put an ambulatory surgery facility in the backyard of the hospital and steer, commercial pay, high-paying patients to that and other patients to the hospital, the hospital cannot use that in evaluating whether or not to allow that physician on their medical staff. That is, the laws around the country, the courts around the country have been, particularly in the U.S. Court of Appeals and the Fourth Circuit, where South Carolina is located, have said that hospitals had that ability to use economic criteria as evaluating a physician. There certainly was no prohibition to it, but now you have a state law saying it's prohibited, and if that's held up, that's an interesting development and really tying the hands of hospitals. So not only will hospitals now have to deal with the proliferation of these facilities, difficulty staffing their facilities, but now also not having the ability to use economic criteria in evaluating who can be on their medical staff.
So health plans, insurance companies will be able to use economic credentialing and economic issues to determine who gets in their network, but hospitals can't use that same information as to who is on their medical staff.
Yeah, this didn't say that physicians, for example, can't use that in deciding, for example, who gets to work at their medical practice.
Right.
Or to be a staff on their ambulatory surgery facility, to be on their medical staff. It only precludes hospitals from using economic criteria. So I don't know if there'll be an equal protection challenge to that or some other challenge, but it's quite a development, and I think has really put hospitals in some respects on their heels a little bit, yeah.
Well, let's talk about the DHEC restructuring bill. So the Department of Health and Environmental Control in South Carolina is essentially the state health department, and it has been administering CON and other health-related licensing regulations for decades, but no longer. Let's talk about what the legislature did in terms of restructuring the healthcare regulatory framework in South Carolina.
Yep. So the restructuring bill, kind of abolishing, splitting up, splintering DHEC has been another one of those sort of major initiatives that's been tried many times over the years and has never been successful. Got close last year, didn't make it out of the House, but then here we are this year. Late last month, the General Assembly passed it. I don't know if it had the overwhelming support that CON did, but I'm sure it was pretty close. Governor McMaster signed it, and so it doesn't take effect immediately. So it's actually, I think, July 1 of 2024 is when it will, at least sort of these primary provisions will go into effect, but there will no longer be a DHEC. So the Department of Health and Environmental Control is gone. The board of DHEC is abolished. And there will be two newly created agencies, Department of Public Health and the Department of Environmental Services. And so kind of as it sounds, the public health issues will be directed to the Department of Public Health, Environmental Services, just like it sounds. And interestingly, so last year, a similar bill, I think it was Senate Bill 2, did not pass. And part of the concern, as I sort of understand it from the House side, was that it needed more thought. It needed some more analysis and assessment before we did something so significant. And so in this bill, it did pass, but it includes sort of a pretty detailed requirement that the Department of Administration, I think, conduct an analysis through third-party consultants, and bring in folks to help them understand, okay, what are ways that we can make sure we're fulfilling the missions necessary for all of these important initiatives? What does it need to look like? So they've made a plan, or I guess they've set a date for the end of DHEC, but they don't actually tell us what that will look like or what will happen. And actually, before we came here, Ralph and I were sort of just troubleshooting through some examples of, well, what would happen with X? And the answer is no one knows, because you now have statutes that you can't read together with these changes.
Yeah, even something as simple, you go back to CON, for example, if after July 1, 2024, you have a CON application for a new hospital pending, that application, let's say, is approved, and a party challenging wants to challenge that application, are we going to have the request for final review process? There used to be to the DHEC board. Of course, there won't be a DHEC board come July of 2024. So does that go straight to the administrative law court? I would think that it will.
Still have to do some legislative cleanup.
But there will. It seems like at least on the process,
side.
Right.
On the health side, there will be some future cleanup.
And there are thousands of DHEC employees, right?
It's the largest. I believe I had looked at this last. It's the largest state employer.
Yeah.
It has the most employees of any state agency.
So this is not only affects the healthcare industry. You've got thousands of individuals who are saying, all right, I guess if they worked in the environmental section, presumably that's where they're going to go, into this new environmental agency, and likewise.
And what are the other departments that are affected by this? It's not just DHEC, right?
Yeah, so DHEC is the one getting, we know the plan has been made. It will be split into these two. Part of the analysis that the Department of Administration has to undertake is they are also looking at other agencies. So last year's bill, which was unsuccessful, had a greater impact. It was going to be abolishing Department of Mental Health, the Department of Alcohol and other drug abuse. There were maybe 3 or 4 other agencies. It was a very big plan without maybe a plan. And so this bill is making it clear that DHEC will be splintered, but that analysis that needs to be undertaken by the Department of Administration is supposed to make recommendations that may include, for example, the Department of Mental Health being subsumed and those things. So there's a number of agencies that may also be impacted in terms of restructuring, and then some smaller programming issues. So they definitely put a lot more assessment into the environmental services side in the bill that has now become law. So there are provisions related to sort of the review process for environmental services. There's a program, I think, at DNR that's coming over to the Department of Environmental Services. So those things have been provided for, but on the public health side, is sort of a to be determined.
And what are some of the other regulatory issues at play here for the landscape in South Carolina?
Beyond the restructuring, and yeah.
Well, the one that I think to keep an eye on is a bill that was introduced in the House, and I think is still pending in the House Judiciary Committee, is a bill that, and I think it ties kind of to this issue of conflict of interest or economic credentialing that I was just talking about.
Because this part was in the original.
Yeah, this was in the original Senate bill, I believe, Jennifer, if I'm right.
Yep.
That did not actually make it through as part of the CON reform legislation that passed, Act 20, but it was carved out, but now found its way into a standalone bill that is pending in the legislature and will be carried over to next year, I think, which deals with this covenants not to compete or non-competition clauses that you see in many contracts, not just in the healthcare industry, but all across the landscape of American business, which is, you employ an executive, you employ a physician, you employ whoever it may be, and that person signs a covenant not to compete that after their employment ends, they, for a period of time, won't work or compete in a particular geographic area for a short period of time. And what the legislature has done, or is considering, I should say, is focusing that on healthcare facilities and precluding healthcare facilities from entering into covenants not to compete with physicians. So it's limited to healthcare facilities and physicians, which again is interesting. That again, there was push to have that included in the CON bill, and that would have, there are, Matthew, thousands of employment agreements between hospitals and physicians in this state that are currently in place. And certainly that is a big part or important part of a hospital's consideration in entering into a relationship with a physician. So that could be a significant wholesale change in the way business is done in healthcare in South Carolina.
And the timing of that is interesting because the Federal Trade Commission has a proposed rule that would eliminate non-competition or non-competes across the board, across the country. And there's a big question of whether they have the jurisdiction to do that, but that's likely coming in 2024. Another point is that the South Carolina Supreme Court has upheld physician non-competes if they're reasonable in scope and duration several times. So the courts have looked at these issues and said that they're okay to do within reason. And so this would be another legislative change to that. So that would be profound, I agree, and not good for the hospitals. And they've taken it on the chin coming out of COVID, because the hospitals were one of the places that didn't shut down and didn't limit services, and were 24/7, 365 businesses that were the sharp end of the spear for dealing with COVID. So it will remain to be seen as to how that works.
Well, thank you very much for all of you downloading that information for us. We could go on and on about this. As Matthew said, these are topics that we could go on for hours about, but we don't have that kind of time. Thank you all for being with us today, Jennifer, Ralph, Matthew, and we'll see you next time on Taking the Pulse.